Welcome back. Let's talk a bit here about anxiolytics and sedative hypnotics. We'll talk about treatments for both anxiety and for insomnia in this block. Uh, and they're the drugs we use, at least have historically used, versus the drugs we use now are a little different. We used to rely much more on benzodiazepines than we do now because we see that so many patients over the last 30, 40 years have started on a benzo for intended a short to moderate duration of therapy and found it very difficult to come off of them. So we'll speak a little bit about the alternatives we use in just a bit. When we think of anybody who either has insomnia or agitation or anxiety, as a pharmacist, I'm trained to kind of look through the med list and see, is there anything in the diet or in their med list that could suggest it's precipitating the problem or contributing to the problem. And so there's a whole list of things to think about. First of all, anything that's potentially stimulating and or for which the withdrawal of the drug could be contributing to agitation or insomnia or something like that. So we see a sort of a standard list of the kind of things we see on this slide, both stimulants. We also have some of the drugs and central nervous system agents that work on the autonomic nervous system with the central nervous system involvement. Clonidine, for example, or the lipid-soluble beta blockers can sometimes cause a problem. They're not usually what we consider the main culprits, but we see enough cases where they're contributory, important to consider the risk-benefit of those therapies. So as we think about the treatments, and we'll go through the class of drugs here, let's quickly sort of frame out what it is that we use in this day and age for anxiety, then talk about the drugs, and finally wrap it up with talking about management of anxiety and management of insomnia. For anxiety, the first-line therapies these days, including certainly behavioral approaches and cognitive therapies and counseling kind of issues. Those are sort of really the mainstay. But in addition to that, we commonly will give either an SSRI or an SNRI antidepressant as first-line therapy. That's become pretty much routine now in the last decade or so. So expect that anybody who comes with anxiety or many of these anxiety-related conditions, the first long-term answer is going to be the starting of usually a lower dose SSRI or SNRI. Benzos have historically been used. You still can use benzos short-term, but they're not considered a first-line agent. They usually long-term don't work better than SSRIs or SNRIs for anxiety, and they're wrought with all kinds of problems, habituation, difficulty with withdrawal, contributing to somnolence and falls risk in older patients, and lots of things. So benzos are something we will talk about, but in practice, we don't really use them very often for long-term management anxiety. That said, episodic anxiety, anxiety related to going into an MRI or a procedure, pretty common to use low-dose benzos for that purpose, but not for extended periods of times where individuals are going to likely become habituated and then may have difficulty coming off. Other therapies for anxieties include antihistamines, buspirone, beta blockers, clonidine, prazosin, and there's even some evolving data about whether medical marijuana is a reasonable alternative. We'll talk about all of those at least briefly in this block. Next is the question of insomnia. For insomnia, we used to also use benzos pretty commonly, but we find that that renders more trouble often than benefit long-term, that they don't often work long-term, and then you've got the difficulty in trying to get somebody weaned off a benzo. Usually the first step in insomnia is going to be non-drug interventions. You want to know why they're having insomnia. Is it untreated depression? Is it sleep apnea? Is it some other etiology, stress, anxiety, caffeine? What is it that you need to figure that out? For the drugs we'll talk about, we could use a sedating antidepressant. Most commonly, that's going to be trazodone. There's some data that for people to consider using the other sedating antidepressant, doxepin, but I don't see that used very often. Melatonin is pretty commonly put on regimens for patients. The data is not superb. The data for melatonin we'll talk about is a little bit helpful, but as most of the data is for jet lag, not so much, or sleep, people who are having trouble getting into a rhythm of sleep patterns day and night, particularly folks who work night shift and then trying to come to day or night shift. Antihistamines are sometimes used for sedation. They'll commonly be in things like NyQuil or ZQuil or one of those or over-the-counter preparations for insomnia, but they're associated with a lot of antimuscarinic side effects, so we have to watch for that. As we alluded to, benzos historically have been used, and there's a benzo wannabes. There's a lot of drugs that are related to benzos that I consider them benzos, even though they're officially considered a class. We'll talk about those drugs. There's a pretty much brand new agent, an orexin receptor antagonist, which is new to the market. I'm always skeptical about something that's new to the market. We don't really, how many years of experience do we have for safety data? I think most of the studies that were published here were only for 3 months. And we don't really know if there are long-term consequences. So I'm a little skeptical about new things that come to market. And then there's a host of complementary alternative regimens for which the data is iffy. Don't assume just because it's a complementary alternative therapy that it's necessarily safer or more effective or less harmful, or, some of these drugs interact with other drugs. We may not know that all that well. They may have some hangover effects and other things. So that's the context, really. And in a sense, you know a lot about these drugs already, or many of them already. But let's go through the drugs more specifically. We're going to start with the benzodiazepines because the benzos have been around for a while. They first developed in the 1960s. They are GABAergic. They work as triggering GABA receptors, which results in slowing down neuronal conduction. They cause changes in neuronal firing related to the influx of chloride, and so they have a lot of central nervous system effects. There are 3 subset types of benzodiazepine receptors. Benzodiazepine 1, 2, and 3. Their receptors are sort of listed here, and the kind of actions you expect to see with action or a benzodiazepine at each of these receptors. This is in a sense, an image of what the receptor may look like, but the receptors, when the GABA receptors are stimulated, they result in a ion channel transmission of influx of chloride, which affects the nature of slowing down or inhibiting neuronal firing. So what are the actions of benzos? Well, there's multiple actions. They're anxiolytic. They are sedatives. They are great for seizures and a neuroblock. We talk about using these drugs first line for the seizing patient who is in front of you. Their action for seizures, though, isn't a long-term thing. So they're better at stopping an existing seizure or lowering the risk for a seizure happening in the very short term when you use it short term. But when you consider a longer term use of a benzodiazepine, their seizure preventing or their anti-epileptic properties seem to diminish. They're also pretty good skeletal muscle relaxants, but we have other skeletal muscle relaxants that are not benzos that are probably preferable because benzos are habituating their Schedule 4 drugs. Benzos themselves aren't analgesic. Now, the degree to which anxiety is contributing to the perception of pain and or muscle spasms are contributing to the degree of pain someone has, then yes, they may offer some comfort there. But as such, they're not really analgesics per se. So when do we use benzos? Well, they can be used for anxiety disorders. Usually we only consider using them for pretty severe anxiety disorders and only pretty much short term. Muscle spasms, they work pretty well. The older, longer-acting drug, diazepam, would be considered the drug of choice if you're picking a benzo for that. But in general, we don't even like to use benzos at all long-term if we can get by with something else. They're great for seizures. They're first line, particularly lorazepam, maybe midazolam for status epilepticus. We talk about that in neurology. And some of the benzos have also been used for alcohol withdrawal syndromes, and we'll talk about that in the substance use disorder block. Finally, they are occasionally used in sleep disorders and insomnia, but again, tolerance develops quickly, and you end up often with a patient who you have trouble with getting them off the benzo. So pretty limited in benzos. Where do I see benzos used most often in practice? In acute care, episodically for the patient who's in an anxiety crisis, often in the emergency room or in the hospital short term, to quiet a patient down or to help with a patient who may have a lot of anxiety about a procedure coming up or something like that. But we're pretty hesitant about having patients on benzos long term. And so in primary care, benzos are, use in general is pretty scrutinized, and we try not to start somebody on a benzo. That said, you will inherit a number of patients who have orders for benzos, and your job is often going to be to try to evaluate the risk benefit of that long-term benzo and being careful about how to wean that patient off of the benzo if there's not a compelling reason to keep them on it. Adverse effects of benzos, they sometimes cause GI upset or nausea occasionally, but more common, patients often will have blurry vision, incoordination. They'll almost look like they're drunk. Now, occasionally, you have these paradoxical reactions to benzos. Those are kind of listed in the right-hand side here. You would not expect restlessness, insomnia, and seizures. That sometimes happens paradoxically when you start a benzo or increase the dose of one. Although, truth be told, more commonly, that's seen for patients on benzos when they're going through benzo withdrawal. So benzo withdrawal is more problematic, causing seizure risk, restlessness, and insomnia. So you want to be kind of careful about benzos are a little difficult to manage or work with patients on them. Here's a list of some of the more common benzos we use in this day and age. One is the short-term alprazolam or Xanax. I don't see this used in acute care like at all, but it's sometimes used in ambulatory care, particularly as an as-needed when somebody has a big anxiety state. But you'll see a lot of patients you'll inherit who have orders for it, and it's pretty difficult to kind of rein that in a bit. The older chlordiazepoxide of Librium has a pretty long half-life. It's troublesome for patients to, have hangover effects. They feel sluggish the next day. It is used or has historically been used in alcohol withdrawal protocols, but other than that, it's not all that often do you see it used. Clonazepam mostly for seizures. Diazepam, probably seizures. And then lorazepam is given IV or oral, relatively short half-life. That's a pretty commonly used agent across the board. Lorazepam is probably the most commonly used benzo. The one that's not listed here, but we talk about more for procedural sedation. We do that another time in the year. We talk about surgery and anesthesia and procedural sedation, is midazolam as another benzo that is shorter acting. We think of a few things with benzos. Older patients often accumulate benzos more so than younger patients. They're fat-soluble drugs, so they hang out in body fat, and so they might have a longer half-life because of that. Depending on the agent, and if someone's has significant liver disease, it may hang around a bit more. The other thing that's pretty common is that some patients there seems to be a pretty wide variation in patient response, possibly genetically as part of it. And the other component here is if people get tolerant to benzos, it's amazing how much benzo they can tolerate before they get the least bit sedated. So expect to see variation in response to benzos, and you'll pretty much see that in practice as well. We worry about dependence. We worry about drowsiness, confusion. Actually, One of the concerns why we don't like to use benzos in our ICU settings, for example, is that often actually throws someone into delirium. They get confused, they're amnestic, they don't remember things, and then they lose their sense of orientation. They get fearful because they're disoriented, and it kind of ramps them up into a state of delirium. So we're really careful about that. We also avoid benzos in patients who have predisposed to dementia as well. The symptoms of benzo withdrawal we worry about primarily is the classic things you think of why you might have given the benzo in the first place, and the withdrawal sort of accentuates the anxiety, insomnia, or irritability that somebody may have. There is a reversal agent for benzo overdose. It's flumazenil or romazicon. But the issue here, when you think about giving a benzo antagonist, is you want to be careful about actually precipitating withdrawal, particularly somebody who has a risk for seizures. So we don't use it very often. If you have a multi-drug overdose where benzos are part of the equation, but you're not sure what else is on board, we won't want to use this. The reason is because you may find that something else that they have on board precipitates seizure activity. For example, if they've had stimulants on board and they start seizing, then you give them flumazenil to reverse the benzo. You have two problems there. One is that they start seizing because you're giving them, you're throwing in the benzo withdrawal, plus they may have another drug on board that predisposes seizure activity for them as well. So flumazenil, even though it sounds like a great idea, we don't use it very often. The only settings I've seen flumazenil used is when you know the patient well, they don't have any other drugs on board, they don't have a seizure history, they're coming out of a procedural sedation issue, and for whatever reason, the benzo effects is hanging much longer than you expected, and you might consider a little flumazenil to kind of wake them up a bit. But that said, that's about the only use I see for it. It's frankly dangerous to use flumazenil in someone who has a risk for seizures either at baseline or because of the other drugs that may be on board. We have a few non-benzos that I want to talk about briefly that are used for anxiety. The big ones are, and we've already talked about the SSRI and SNRI antidepressants. Those are the first-line treatment for anxiety. There's another agent called Buspar or buspirone. It has a high affinity for serotonin subset 1 receptors. But the issue with Buspar is it may offer some modest benefit in anxiety, but it takes a while to kick in. A lot of patients don't get a lot of benefit from it. Occasionally, though, there are patients who we've heard have gotten a great benefit from it. And so Buspar is a lower risk agent to consider. It's not a benzo. It may offer some degree of help with anxiety, but a lot of clinicians have kind of not necessarily used it or picks and chooses the patient who gets it because it probably doesn't work all that well. But it's generic, it's cheap. The biggest thing you have to worry about is dizziness and falls risk for patients, and usually that's a pretty manageable kind of thing. In many patients for whom you want to avoid a benzo, but you want to have them a bit sedated, and the sedation contributes to reducing anxiety, are patients who are undergoing withdrawal, particular opioid withdrawal. Very commonly, in those individuals who have a substance use disorder for which you want to give an anxiolytic, the protocol drug that's almost always used is hydroxyzine, Atarax, or Vistaril. You have to keep in mind this is pretty antimuscarinic, anticholinergic, dry mouth, urinary retention. If it's an older patient, you could get more confusion. If it's an older male, you could get more BPH and urinary retention. So you're thinking about all those things. But very common to see hydroxyzine in protocols for alcohol withdrawal, but even more commonly in opioid withdrawal. And if the nature of the anxiety state, like panic disorders or something else, has a pretty high risk for or potential for tachycardia and palpitations and the kind of autonomic nervous system overdrive that contributes to, we sometimes look to blunt the autonomic nervous system with drugs like beta blockers or clonidine or prazosin, for example. Sometimes those are also helpful in patients with post-traumatic stress. It's kind of a pick and choose. The data for them isn't superb, but you're kind of looking at, okay, well, you're trying to look at an additional thing that's going to help the symptoms, particularly if there are autonomic nervous system symptoms involved in their presentation for their anxiety state, then they might play a role. There are a couple of officially non-benzo sedatives. These are drugs like Ambien and Sonata, and these actually have affinity for the benzodiazepine 1 receptor. In a sense, they walk like a benzo, they talk like a benzo. In my mind, they're a benzo. They're also control drugs. And so I don't see these drugs all that much different from a benzodiazepine to use for sedation. They're a little more precise in which benzoreceptor they bind to, but patients can run into trouble with these drugs too. So I've not seen a lot of use of these drugs in the last 5 to 10 years. They were much more common 10 years ago. These drugs, like the benzos for insomnia, associated with hangover effects and sleepwalking, and then people still have trouble with withdrawal when they're coming off of them. There are a few non-benzo sedative agents. The one I think of most often is any of the sedating antihistamines, particularly diphenhydramine or Benadryl. That's often a very common ingredient over-the-counter preps for insomnia, but they're very antimuscarinic, so you need to be aware of that. Melatonin and melatonin-related derivatives like Roserum are helpful, but most of the data for melatonin are really done in jet lag or people who change work cycles from night shift to day shift or something like that, where melatonin secretion typically happens when your bodies are triggering trying to fall asleep, or when your body's telling you to go to sleep, and so it augments that. But melatonin, the data is not perfect. Some patients have trouble with it when you start to get to doses above 5 milligrams. And finally, there's a brand new non-benzodiazepine agent for insomnia that's just been on the market in the last year. And this is an oxytocin receptor antagonist. It's dosed pretty much 25 to 50 milligrams per night, interacts with the cytochrome P450-3A4 inhibitor, so there's lots of interactions there. And here's a drug that's been new to the market. For the studies I've seen, they only have gone out for 3 months duration or so. And this is likely a drug somebody's going to want to be on for a long time, or at least intermittently for a long time. So I'm a little hesitant, it's my nature to be hesitant about a new drug or new class of drugs that comes to market, about its safety and efficacy if it hasn't been studied in huge numbers of patients. And, when a drug comes to market, typically, it's studied by, in studies in something like, anywhere from 1,000 to maybe 5,000 or 6,000 patients. That seems like a lot. But if you have rare but serious adverse effects, you may never find that out in a newly released drug. So my sense is I have a hesitancy about a new drug that may offer some benefit when there are other modalities that may work well, unless there's a compelling reason to use it. And usually with insomnia, you're going to do non-drug things and other things before you start to go down this road. So I'd be hesitant. I might consider the selection of it for a very limited patient population, but not very often. Finally, the drugs for complementary alternative meds that are considered, there are many of them. I just selected 3 out of the bunch here. Valerian. Valerian has been around Valerian root around for a long time. In World War II, it was a common agent for sedation, particularly was the most common sedative used in London during the bombings of London in World War II to help people sleep through it in the bomb shelters. Kava or kava kava, some people consider it nature's benzodiazepine in a sense. Earlier, about a decade or two ago, there were lots of reports of the formulations of kava resulting in hepatotoxicity. It's unclear if that was a contaminant or if that was the drug itself. But patients have a little hesitancy, or clinicians have a hesitancy about using it. Things like chamomile tea, and there's lots of other things that could be considered. But for the most part, you probably would, this would be probably a decision the patient would consider comes to you or they want to use something natural alternative, you encourage them them to be honest with you. We don't know a lot about the adverse effects of some of these natural products. They're not necessarily standardized. And so adverse effects and interactions are something that's a little bit of an unknown with these. Finally, the role for marijuana, medical marijuana, particularly in anxiety states, is evolving. And I think we all may know patients who have found that marijuana in moderate doses may help keep them calm, cool, and collected where nothing else has. But the data to support that it's evolving. And some patients are going to be very amenable to that. Other patients are not. You've also got to consider if there is, for example, drug testing for someone who might be taking chronic marijuana. Well, marijuana for someone who chronically takes marijuana will stay in the urine for up to a month. So that might affect their job eligibility or on top of whether or not they're even amenable to consider using it. Plus, we'll talk about throughout the year, we don't really, as clinicians, don't really recommend marijuana per se, but if you work or practice in a state where marijuana is available to patients, you could be clear with them, I have no problem if you want to consider doing it. It may help you, but that's kind of your choice and you figure that out for yourself. Just let me know if you decide to go on it and I'll help you monitor any problems associated with it. Okay. But all of those are the drugs we have in the toolbox. Okay, let's briefly go on to, what's the issue? How do we use these drugs or other things, modalities, in treating a couple conditions, anxiety and insomnia? Let's go through that quickly first. Starting with anxiety, this is a set of guidelines that was published about a year ago, and it's not the best data, but it's reasonable summary of where we are. There really is, if you look at the second sort of line item here, SSRIs and SNRIs are really the first line treatment for generalized anxiety disorder and panic disorder. So SSRIs, SNRIs, that's really where the data's at. That's the strongest level of data. And in addition, down here, another grade A evidence kind of data is psychotherapy for a host of panic disorder or global anxiety disorder situation, and cognitive behavioral therapies are really helpful. So that's really where our emphasis should be for these anxiety states. Benzos, as they list here, aren't any more effective than the antidepressants are in general. Plus, their scheduled drugs. Patients start on them; they can't stop them. They have withdrawal. There's all kinds of problems with that. So really, benzos, you really want to be hesitant about not starting somebody on a benzo. And the antidepressants, when they're used, you really have to try them for 6 months to a year before you determine whether or not they're really effective or not. Okay. The other issue we've talked about is physical activity. Sunlight helps with depression. It helps with mental clearing. Mindfulness helps. All of these sort of modalities really can help a lot with anxiety states. As far as other sort of things to think about, and I'll leave some of this to the ClinMed folks who are going to go through this or have gone through this with you, here's some differentiation for some of the more common anxiety states. There's generalized anxiety disorder, there's panic disorder, OCD, post-traumatic stress, social anxiety disorder, and specific phobias. For generalized anxiety disorder, again, SSRIs, SNRIs, cognitive and or psychotherapy are helpful. For panic disorder, we probably will also see the SSRI, SNRIs. Sometimes there's a good case to make for a trial of a beta blocker, clonidine, or maybe even prazosin for that. For OCD, there's a reasonable amount of data for the addition of some of the antidepressants, SSRIs, SNRIs. Even there's some data for the older tricyclic antidepressants that have had a reasonable track record for OCD. For post-traumatic stress, not a lot of drug therapy is going to help. I have seen a subset of patients get benefit from the use of maybe prazosin or beta blockers or something when they have an autonomic overdrive as a component of that. I think the other area that we're investigating with all of this consideration with both refractory depression and post-traumatic stress is whether neuroplasticity modalities, including we had some discussion about ketamine in its use for refractory depression. But the concern with ketamine is that you would only want to do that, or whether you're talking about psilocybin or one of these psychotropic agents that allow for some degree of neuroplasticity, and people have a sort of a different reframing of an issue, might be very helpful in post-traumatic stress, but that should be really only done in an environment where there are really pretty much either an inpatient or have really good structures around. And because some of these therapies that will change neuroplasticity could actually be very traumatic themselves to a patient to sort of relive their nightmares. So you want to be really careful about that. Okay. Social anxiety disorders, very commonly some of these are, again, if it's preventable, predictable, like a speaking anxiety or a certain trigger, biotherapy is a big benefit here, as well as sometimes, again, beta blockers short-term when they're exposed to that trigger. And that might also be the case for specific phobias. The antidepressants for anxiety disorders are tried and true. We've used them for a couple of decades now, and we are careful about how we try them and use them. The one I see used most often, but other clinicians may see differently, is usually low-dose escitalopram or Lexapro, but really many of them may be pretty effective, and you kind of pick and choose which agents work well or not. There are other drugs that can be used for anxiety we've alluded to again. Buspirone we talked about briefly, beta blockers when there's an autonomic nervous system involvement. MAO inhibitors, I would be quite hesitant about that. And I would say that even though it's listed here, but that I would leave that to patients who have failed everything else, and even the data for that is somewhat limited, and so be careful about that. Hydroxyzine, pretty sedating antimuscarinic, but we see that used a lot in patients who have a risk for substance use disorders. And antipsychotics generally aren't very helpful for anxiety states. So let's talk about benzos. So benzos you'd think would be great for anxiety, but and they have long and short half-lives depending on the agent. They have lots of qualities associated with them, but the concerns are tolerance develops, dependence develops. You create a new problem for them when you start a benzo, and that they become habituated often to it. And then it becomes difficult for them to come off of the benzo. So we're really careful about benzos and using them and how we use them. Other things that might see used, so let's go through some states again. General anxiety disorder, maybe benzos would work, but we want the antidepressants first and other options before we do that with cognitive therapy. Panic disorder, again, benzos in a short term will help maybe, but the antidepressants are a better answer, and cognitive therapy also a good answer. For obsessive compulsive disorders, the SSRIs and clomipramine, an older tricyclic antidepressant, have reasonably good track records there. For post-traumatic stress, not a lot. I think sertraline or paroxetine are considered the antidepressants that have had more tried data with it, but post-traumatic stress is a thorny kind of issue. There's other drugs. Some of the anti-epileptic drugs might have been tried with varying effects. I'd refer to the experts. And in post-traumatic stress, among the clinicians who have the most experience there is the Veterans Administration. So the VA has a lot of data, and occasionally they publish guidelines as far as how to manage or updates in managing post-traumatic stress with both meds and other modalities. All right, finally, let's talk a bit about insomnia. We think about patients who will come to you with a sleep disorder. Usually insomnia is the one we think of most often. You want to keep in mind what the stages of sleep are, and that we're really trying to encourage a good amount of REM sleep as part of that sleep, which is the most restorative type of sleep in stages 3 and 4. Insomnia generally is defined as patients who have difficulty either initiating or maintaining sleep. They might have sleep pattern that incorporates daytime napping or something else, and their risk for automobile accidents and trauma and all kinds of consequences with their sleep disorder. The primary disorders involve either not sleeping or sleeping too much, or narcolepsy, or breathing-related disorders like sleep apnea. And so when you think about any sleep disorder, you really want to get some good data about why they're having the sleep disorder. Is it sleep apnea? Is it something else? And get to that root issue and not necessarily just throw drugs at insomnia. The type or nature of the insomnia, whether it's transient or short-term or long-term, is important in how we assess insomnia, as well as the time do they have trouble falling asleep or staying asleep or early morning awakenings? What's the pattern of their insomnia? And what correlates with that? Is there stressors? Is there food and diet? Are there drugs? Is there something else that's correlated with their insomnia presentation? All of that meaning you've got to do a little legwork to figure out the why of things. And if you've ruled everything else out, then maybe drug therapy might make sense. There's concepts about what is good sleep hygiene. That includes things on this chart. I'll encourage you to spend a little time at some point talking about what is good sleep hygiene. You can go add to your favorite internet search engine for good sleep hygiene practices, and you'll find a whole wealth of things there. As far as meds go for sleep, behavioral therapy probably works better long-term than the meds do. The meds are not really a long-term answer for insomnia. So we are a little hesitant. In this day and age, we don't see them used nearly the way they were used a few decades back. You also want to think about sleep disorders and that are particularly like apnea, obstructive apnea, as it relates to risks for depression, diabetes, hypersomnia during the day, obesity, cardiovascular disease. So you really want to get to the root of somebody who has insomnia. You want to rule out obstructive sleep apnea as a big deal here. The non-benzos for sedatives are the antihistamines, which we don't often recommend. They don't really work that well long-term. They're antimuscarinic, so you're worried about all of those effects. Melatonin is what I probably see clinicians go with the most often. It's probably the do no harm intervention. Probably doesn't do a lot. But if you're keeping to low to moderate doses of melatonin, I think in nursing homes we see that a fair amount. You might see trazodone pretty commonly used, as we alluded to. And then we talked briefly about this new orexin receptor antagonist. The complementary alternative meds are valerian, again, we spoke of, kava we spoke of, and marijuana we spoke of. And you really try good sleep hygiene practices, try to rule out and figure out why. If you're going to use something, short, low dose, one night trial, a couple of night trial, not for long term, and try to work on other things. When you use drug therapy, get ready for rebound insomnia the first night they stop taking it. So benzos are historically used. Almost no one uses these agents anymore. I don't see them used in the hospital at all anymore, really. And these are older agents that really are not all that commonly used. As we alluded to, tolerance, daytime sedation, and rebound insomnia are the big concerns. We also see with benzos amnesia, which is why we use them in sedative procedural sedation. We don't want people to remember their colonoscopy, but that's problematic for someone who doesn't remember what happened yesterday. And withdrawal is pretty common when folks are using benzos routinely. And these benzo, non-benzos, some of the non-benzos listed here include Sonata and Ambien, a few others that I wouldn't even recommend hardly at all anyway. And the rest of them we've talked about, some of them briefly. The last thing I want to mention is that when we use sedatives in older individuals, this comes back, data is quite old, but it's tried and true. sedatives just have bad outcomes for older patients. They have more falls risks, they have more confusion, there's more chance for delirium. And so you really want to avoid sedatives, particularly in older patients. It really impairs their cognition, and the benefits are, are pretty significant. You need 13 patients to have a beneficial effect for most sedatives in older patients, whereas you only need to treat 6 patients before one of those patients is harmed or has a negative outcome. Okay?